this topic. I'm very happy again to be with all of you, and I hope you will gain the maximum benefit from this session to start a proper preparation for MRCOG exams under the guidance of MedExam Expert, which is a famous leader in the field of MRCOG preparations, and we had a lot of years in this field, and thus we have a lot of experience as well. I will start by simplify the TOG article and how can you read the TOG article, because in the last 2 years, I think that the RCOG policy regarding the exam of part 2 is markedly shifted from the green top guidelines, the NICE guidelines. Hi, Dr. Preeti, how are you? It's very nice to see you here in this room. Thank you so much. And then they tried to change the bank of question. And then we have fixed number of green top guidelines. Maybe updated guidelines are not that regularly presenting on the website. So we need to find another source of questions. And this is the plan. They are trying to build up a new bank of questions. So they found that the TOG, which is released 4 times annually in 4 volumes, each volume about 6 to 8 editions or papers, this is a very good source for questions, okay? That's why the TOG articles' importance raising up in the last 2 years. And that's why we need to focus more and more on the TOG articles. This is regarding the policy of the college, and we have to adapt with this policy so that we can cope with the exam and pass the exam successfully. Okay. Dr. Najwa, thank you. You are the best. Thank you so much. So regarding this, you need to understand what is important and what is less important in the articles. This is our mission, to supply all of you by the list of important TOGs and less important or not important at all. We will provide you about this list, of course. Now, how to read it, how to read the paper, a long of paragraphs, multiple information, but we have to stress on certain informations. Today's session is a very good example. How can you extract the positive points, the important points, and neglect others? Let's start by a simple intro, which is not important at all in the exam, for example, but it's important to start this session. The adolescent ovarian cysts are most commonly benign in origin. Very rare to find a malignant adolescent ovarian mass. The risk of malignancy is low, despite the possibility of malignancies may be in certain situations related either to a positive family history for ovarian cancers or raising up some landmarks, important landmarks, like tumor markers, for example. And this is what we will discuss right now. And then a multidisciplinary team should be involved in the management of highly suspicious lesions, including a gynecologist, pediatric surgeon, or maybe general surgeon if pediatric surgeon is not available. Number 1, the first group, according to the age, is neonatal cysts presentations. The most common cause of abdominal cysts in female fetus or neonates. It means that sometimes when you are doing a 3D ultrasound or a follow-up ultrasound for a fetus, you may find a mass intraperitoneal. This mass, most probably ovarian in origin. So this is number 1. What is the most common cause of abdominal cysts in female fetus. It's ovarian origin mass or cyst. Why it could happen? Because mostly it's related to maternal estrogen high levels or a fetal hypergonadotrophic status, or the HCG itself may be stimulus for ovarian cysts in female fetus. So 3 reasons for possibly ovarian cysts developed in a female fetus, in utero. After the delivery, the neonates may present with ovarian cysts as well, and it will be also directly related to the 3 causes we discussed before. Management is almost conservative unless the mass is large or there is a suspicious torsion or complicated cyst. Now, this is a very, very wide expression. What is meant by the cyst is large? Is it 3 centimeters considered large? 5 centimeters? 20 centimeters? What is the cutoff? Simply, it's related to the size, and the size of 5 centimeters is considered the upper limit of accepted conservative management. This is in fetus, female fetus. In comparison to adult woman, it may be up to 7 centimeters. Okay, so this is to be more accurate. Now, the second group in this paper you need to remember very well. This classification related to benign ovarian tumors and malignant ovarian tumors. The benign, which considered the majority, about 90% of cases, simple cyst is about 60%. And this is the most common type of cysts in adolescents. Complex cyst, teratomas, considered the most common complex cyst. Endometrioma or other tumors are less common. Benign masses are less common. Tubal ovarian abscess is extremely rare in the adolescent or non-sexually active girl. And of course, possibility of ovarian torsion, which is a common condition, especially with acute lower abdominal pain suddenly. And the maximum or the most important age to develop ovarian torsion or to suspect ovarian torsion is between 9 to 12 years old. Malignant tumors are about 10%, maximum 15% of adolescent ovarian cysts. Most commonly, juvenile granulosa cell tumor, and we will discuss it later. Less common, the germ cell tumors. Extremely rare, epithelial tumors like serous adenocarcinoma or mucinous adenocarcinoma, because the epithelial tumors are more common or the most common in adult patients, not adolescent patients. Okay. The complex benign cysts, germ cell tumors, are the most common, like teratomas, okay, in children and adolescents, with up to 70% are a mature dermoid teratoma, and only 10% of them will be bilateral lesions. The risks associated with conservative management, for example, for ovarian benign cysts, may include 1% spontaneous rupture and up to 2% malignant transformation if we have a benign tumor like cystadenoma, okay, mucinous cystadenoma, serous cystadenoma, okay, with a rare possibility for other complications like stroma ovarii or carcinoid tumor. All of you know the stroma ovarii, of course. The stroma ovarii, it's a cells in the ovarian tissue which is increased the levels of thyroid hormones, releasing the thyroid hormones, or maybe sometimes other hormones, and it should be treated by surgical removal. Okay. Gonadoblastoma is a mixed germ cell tumor that characteristically develops in gonadal dysgenesis when there is a presence of Y chromosome. It's very difficult to come like this question in the exam, okay? It's very difficult. But I try to show you this information because sometimes in single best answer, we may have a question like, what is the most common ovarian mass associated with the presence of Y chromosome? It will be the gonadoblastoma. Okay. The malignant ovarian tumors in children and adolescents, maybe up to 50% of them is a granulosa cell tumor. Granulosa cell tumor is a sex-cord tumor. It's related to sex hormone production, excess amounts. The granulosa cell tumors is associated with excess estrogen production. It's called estrogen secreting tumor. About 80% of ovarian tumors with estrogen secreting function present in even adolescent age or very old age. So if you have a case, for example, a girl with 8 years old, for example, and she had a well-developed breast, menarche started, a feminine distribution of hair and a feminine distribution of fat, okay? This girl suffering from a precocious puberty. When you find a scenario like precocious puberty, you have to exclude estrogen secreting tumors, and this is the landmark due to excess estrogen. On the other hand, if we are talking about old age woman, suddenly she had a postmenopausal bleeding. If the scenario said that there is an endometrial thickness and ovarian mass, 100% this mass is granulosa cell tumor. The excess estrogen re-stimulate the dead endometrium, leads to postmenopausal bleeding, but the main source is the ovaries, and so on. Exactly. So the granulosa cell tumor is the most common malignant ovarian tumor in adolescents. Okay. Sometimes it may be associated also with excess androgen secretion, such as clitoral enlargement, hirsutism, deep voice, blah, 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 amenorrhea, or irregular periods. This is what I was talking about. The ovarian neoplasm in childhood and adolescence can be associated with cancer predisposition syndromes. You know, we have a famous TOG article related to inherited malignant tumors in female system. This was released, I think, 2015. And the main issue for this TOG article was the BRCA gene mutation for a familial history of breast cancer and ovarian cancer. This paper also discussed the Lynch-2 syndrome related to a relationship between the endometrial cancer and colonic cancer, for example. There are multiple syndromes like Maffucci syndrome or Bird's-Guth syndrome, Ollier syndrome, multiple syndromes that may be related to development of cancers in a very young age patient. Okay. So at this scenario, the female or the patient familial history survey and questionnaire should be ask it in details. Okay. The precocious puberty is a separate entity and separate topic, but I would like to give you some important tips regarding the precocious puberty as well. We have two causes for precocious puberty, either central causes or peripheral. The central causes are more common. About 75% of cases are related to central causes, mainly idiopathic, with no reason. Sometimes the CNS pathology and lesions, including hamartoma, astrocytoma, multiple tumors of the brain, may lead to this problem. Sometimes meningitis, encephalitis are also considered important causes for precocious puberty, but the peripheral causes should be excluded first, including the ovarian estrogen-secreting tumors, maybe starting from ovarian origin. Or if the ovary is clear, it's maybe from adrenal origin. So adrenal tumors should be excluded as well. Adrenal tumors may be a source of estrogen or androgen secreting tumors. Exogenous hormones should be excluded, okay? And a part of McCone-Albright syndrome, precocious puberty may be presented. The McCone-Albright syndrome is a disease of C's. C's, look at this, just to remember. It's just to remember. McCone, take this C, and you should remember cysts. Where are these cysts? Are there ovarian cysts? No, they are bone cysts. So this is the second C. And finally, the skin of the patient shows café au lait patches. Café au lait patches. So bone cysts, café au lait patches with McCone-Albright and precocious puberty. This is the triad, famous triad of McCone-Albright syndrome. However, the main treatment for the peripheral causes is to treat the cause. If there is a mass, you have to remove the mass. If there is an exogenous hormone replacement treatment, for example, you should stop this exogenous treatment. The central precocious puberty should be treated by GnRH treatment, just to suppress the FSH and LH, and then to break down the cycle of estrogen production. Okay, so this is a very summarized, targeted points related to the precocious puberty management. The fourth group of adnexal problems in adolescence, tubo-ovarian abscess. This problem is rare, especially if the girl or the adolescent patient is not sexually active. However, it's very difficult to be differentiated from the ovarian torsion, which is more common in this situation. But if you have a scenario in exam which is confirmed to be tubo-ovarian abscess in young girl, what should you do? All people will choose admission to the hospital, start long-acting, or according to the culture and sensitivity, start antibiotics, painkillers, whatever the treatment is. But the clue of this scenario is this patient is at high risk of maybe sexual abuse. Tubo-ovarian abscess is most probably related to sexually transmitted infections, unless the patient is immunosuppressed. Maybe with young age patients who are treated from the cancer, for example, or receiving chemotherapy or radiotherapy, or sometimes underwent renal transplantation or something like this, they are suffering from severe immunosuppression. So maybe this is the cause of tubal ovarian abscess. But other than this, there is no reason that a girl about 12 years or 14 years who is not sexually active suffering from tubal ovarian abscess. So don't deal with such scenarios superficially. You have to go in depth, and you have to think about possibility of sexual abuse, which is common in UK. Okay, so this is the trick related to the tubal ovarian abscess in adolescents, for example. Now, the acute TOA must be excluded early when pain is acute, unilateral, associated with vomiting, tachycardia, and fever. Fever is your landmark, because if I remember these points, without fever, surprisingly, it could be ovarian torsion. It could be ovarian torsion easily. The patient will suffer from unilateral pain, guarding tenderness, vomiting due to irritation, tachycardia, yes, from the pain. So all points, actually all points in tubal ovarian abscess, you can find them in ovarian torsion, except the fever. The fever is significant because we have a source of infection in tubal ovarian abscess. But in torsion, low-grade fever, less than 38, may be present. What about the torsion? Wow, it's about 10% incidence. 10% incidence. Just a second, please. Back. So you can imagine the incidence of 10% of patients or girls may suffer from ovarian torsion. So this is a common condition, not a rare or not uncommon condition. The age is between 9 up to 12 and a half, as we said. More common in right side. Now, it's more common on the right side because we believe that the sigmoid colon is fixed on the left iliac fossa area. So it prevents somehow the left side ovarian torsion. Patients are more likely to experience longer duration of pains rather than the acute TOA, okay? The differential diagnosis of torsion, including appendicitis maybe, because we are in the right side, UTI, picture of intestinal obstruction somehow in young patients. It's strongly confused with TOA as well. So you need to be very careful when you are reading such questions in exam, and how can you differentiate between both scenarios, the torsion and TOA. I would like to say something regarding the torsion. If you have a scenario with investigations provided to you in the scenario, CBC or full blood count, FBC, shows mildly elevated TLC, 16, 18 thousands, okay. CRP positive, CRB positive. ESR is high. It's matching very well with infection. I'm right? It's matching with infection. Okay. What do you think? if the patient had this profile of investigations, as well, lower abdominal, sudden pain, acute, unilateral, right side, vomiting, and low-grade fever. Temperature is 37.8, for example. What do you think your diagnosis should be? Torsion or TOA? Any suggestions, my friend? Now all of you are confident enough to choose torsion instead of the high TLC, the positive CRP, and the ESR. Yes, exactly. Because all these parameters will increase with torsion. All these parameters will increase with torsion. Okay? So, this is a very important trick in exam. Your landmark to differentiate between torsion and TOA is the high-grade fever. High-grade fever, okay? Now, the most common presentations you may find in adolescent patients with ovarian cyst, let me say asymptomatic or accidentally discovered situation. This is the most common. This is more common than pain, okay? Sometimes abdominal distension or feeling a mass, maybe some changes in menstrual habits, urinary tract symptoms like dysuria, bowel problems like constipation, which is, both of them are unusual. The most, look at this. The most important findings in acute situations include the ovarian torsion and TOA are fever, low grade in ovarian torsion, high grade in TOA, nausea, vomiting, backache, tenderness over all the abdomen, maybe localized maximally in right or left iliac fossa. But these are the presentations in different scenarios, including the most common asymptomatic finding. It could be appendicitis too. Now, Saim, let's discuss the appendicitis for 1 minute. How can you differentiate appendicitis from torsion or TOA? Let's see the torsion. Think about this. Let's try to think. How can we differentiate? What are the key words for appendicitis over the torsion? What about rebound tenderness? Is it a common expression or finding in ovarian torsion? No, it is not. It's related to appendicitis. Am I right? Yes, Dr. Kinda. And rebound tenderness. Rebound tenderness is a keyword for appendicitis. What else? Appendicitis is associated with absolute constipation, most probably. Okay, so if I have a scenario with a girl with maximum tenderness at the McBurney's point or right iliac fossa, with positive rebound tenderness on the left iliac fossa, with absolute constipation, no urinary symptoms, no menstrual disturbances, no problems at all, okay? Most probably, we are going to appendicitis diagnosis, not ovarian torsion diagnosis, okay? Because the investigations, blood tests as well, will show the same findings. High TLC, CRP positive, ESR is high, similar to the ovarian torsion or TOA. You got my point. Vomiting is very early symptom with appendicitis, rather than it's a late symptom with ovarian torsion and TOA, and so on. Now, these are the keywords, and this is a very important lesson. don't try to memorize everything. You should only remember the keywords, the landmarks, because this is the most important thing in differential diagnosis. And then you can diagnose correctly. The keywords only. They are very important. Don't remember everything. Okay? Investigations. What do you suggest for suspected case of adolescent ovarian cysts? What do you think? If she's not sexually active, transabdominal pelvic ultrasound is the ideal choice, particularly with full bladder, to visualize well. Okay? Actually, the full bladder will be a landmark to identify the uterus and the ovaries through the transabdominal ultrasound. This is your choice. You have to follow the aorta classification, the B, benign criteria, the M, malignant rules, which are very sensitive to diagnose the pre-menopausal and pubertal ovarian problems. If you have a complex ovarian cyst, which is diagnosed by ultrasound, then MRI may be requested. MRI, CT with contrast, all of them are acceptable secondary imaging tools. But the primary imaging tool is transabdominal ultrasound. This is a very important another lesson in exam. Don't never jump to choose the most accurate and most sophisticated method for investigation. It's not like this. Because in exam, I have to identify your knowledge. I have to understand very well your way of thinking. If I asked anyone, not a doctor, okay, what is the best investigation or imaging tool for ovarian mass? I heard about this magnetic resonant imaging, or called MRI. I think it's the best. Okay, what is the difference now between a doctor and non-doctor situation? The doctor should understand the basics, should understand the step ladder wise thinking. So you should start with the easiest, simplest, cheaper options rather than jumping to sophisticated options. This rule should be applied to any topic in the curriculum for part 2 exam. Okay? Other investigations, including the tumor markers. This TOG article actually classify the tumor markers and related tumors in the very simple table in front of you. It's alpha fetoprotein, which matching with teratomas, sometimes Yuxac tumors, embryonal carcinoma. All of them are germ cell tumors. HCG, germ cell tumors. Lactate dehydrogenase, LDH, is a very important landmark, particularly for this germinoma, the germ cell tumors. CA125, epithelial tumors. Estrogen levels high with granulosa cell tumors, and androgen increased levels with sertulidate cell tumors. Okay? This table is important for single pest answers. Now, how to manage? And this is the conflict. How to manage these cases? Now, take a look on this flow chart. If you suspect a patient, you have to categorize this patient. Is she symptomatic or asymptomatic patient? If she's asymptomatic or discovered accidentally during follow-up, or she may present only by precocious puberty symptoms. You have to offer the patient primary step, which is a trans-abdominal ultrasound. This is the primary step. If you find a cyst less than 3 centimeters, offer rescan after 3 months and reassure the girl there is nothing important. If it's a simple cyst, 5 to 7 centimeters, and the patient is, as we said, asymptomatic, it's as same as less than 5 centimeters. Rescan in 3 months, it could be resolved spontaneously. If still persistent, go for tumor markers. Tumor markers also should be directly offered to a girl with 5 to 7 centimeters cyst. If she is symptomatic, either with pain in abdomen, menstrual problems, bowel symptoms, or urinary symptoms. So you should offer tumor markers and maybe MRI, as we said, maybe the second step in imaging tool. How can we manage these problems? The laparoscopic ovarian cystectomy is ideal. Okay. If we have a simple cyst, more than 7 centimeters in diameter, go directly for laparoscopic ovarian cystectomy. Okay? You have to deal, because the large cyst may be ruptured spontaneously, may complicate by torsion, hemorrhage and cyst, so the liability of complications are more, okay, with larger than 7 millimeter cyst. Okay? Thank you, Preddy. Thank you so much. Okay? Now, if we have an emergency acute abdomen with suspected torsion, I will discuss the torsion, and then I will add how to manage TOA in young age patient from my side. Okay, I will do some merge between the TOA TOG article and this article as well. How to manage a patient with acute abdomen suspicious torsion? You can go for laparoscopy if the patient is hemodynamically stable. Okay. If the patient is hemodynamically stable, I can go for laparoscopy and detorsion, which is called ovarian sparing surgery. Whatever the color of the ovaries. Just a second, please. Okay. I muted everybody. I'm sorry for that. Just to keep the room quiet. Okay. So, laparoscopic ovarian sparing surgery is to do detorsion regardless the color of the ovaries or the tubes, regardless everything, just do detorsion. The high vascularity of the ovary, the multiple sources of blood supply, and so on, all of them are very helpful factors to restore the ovarian function again without removal of the necrotic apparently tissues. So this is called ovarian sparing surgery, okay? And this is our option here with torsion. What about emergency acute abdomen patient, suspected tubal ovarian abscess, hospital admission? Start IV treatment, broad spectrum antibiotics, metronidazole and clindamycin. Wait for evaluation for 48 hours to 72 hours. If the patient's not improved, then surgical intervention may be important, okay? Now, this arm is very important in EMQs. Look at this arm. Transabdominal ultrasound revealed non-simple ovarian cyst, a complex ovarian cyst. Complex ovarian cyst may be benign, may be malignant. So I need to go directly for tumor markers, MRI. Tumor markers, MRI, before doing anything to this patient to exclude possible malignant lesion. If there is no suspicion of cancer, go for laparoscopic cystectomy. If there is any high risk cancer, go for a multidisciplinary team. And this is your mission in the exam. Otherwise, there is no tricks in the management of adolescent ovarian cysts. Please remember this flow chart very well, because furtherly, when we will discuss in another session how to manage adult ovarian problems, adult patients, either pre or postmenopausal women with ovarian cysts, we will depend a lot on this scheme of size, either simple size or a simple cyst or complex cyst. Okay? Just a second, please. Now, simply, the laparoscopic ovarian cystectomy is the ideal choice to manage ovarian cysts or ovarian masses. Even in moderate risk of cancer, a gynecology oncologist can go for a closed keyhole surgery like laparoscopic ovarian cystectomy. But if the patient is high malignant risk, there is no way rather than laparotomy, exploration in cancer center with a multidisciplinary team group. Okay? I think this is the summary, explanation, and everything related to the adolescent ovarian cysts. I hope the aim of this session is clear for all of you. And I hope when you try to answer different questions related to this topic, it will be easy. Please don't try to memorize what I said. Try to understand what I said. If you would like to pass the MRCOG exam from the first shot, or to be different in your practice, interpret the knowledge and don't memorize them. Try to understand why, rather than just remember the points. If you understand the points, you will answer clearly in the exam. Okay? Before finishing this session, which I'm really enjoying it, I would like to show you something. Okay. A very important thing related to the preparation. By mid-exam experts, we are happy to introduce the crash course for part 2 preparation MRCOG for January candidates with Dr. Zaid Dr. Helmi, and me. Okay. In this course for January candidates, the course will be, of course, recorded, discussing the GTG's NICE guidelines and other TOG articles, but in a different way. We're gonna do the recalls, and each question we will discuss it and its related sources in few minutes. So you will find yourself covering all recalls possibly, plus a targeted, focused knowledge related to each topic. This is what I call the smart revision rather than hard working. Everybody can study everything. Takes time, effort, but we can minimize the effort and time by targeted bullets towards the exam only. And this is very important. Study rooms with different discussions are also available in the crash course for January candidates. We have the GTG exam pack, including the written summaries, the guideline summaries for PASH, NICE, Faculty of Reproductive and Sexual Health guidelines as well, summaries for RCOG guidelines, Green Top guidelines, and this is available to all candidates for Part 2 crash course. Availability also for mock exam to test yourself once, twice before the real exam are available, okay? With a discount gifted from the mid-exam expert as well to all our warriors and aspirants of Part 2 MRCOG. And from my side, I will be very happy as well to offer the special card for all of you with, I don't know why it's $199. Let's make it $200 directly, okay? Because I don't know why it's $199. I would like to change it to $200, okay? It will be more easy to be remembered, okay? Because, you know, Rina, I'm also laughing, Faiza, because, you know, it's like, I would like to buy anything. What is the salary of this thing, okay? It's $999. What the hell? Just tell me it's $1,000, okay? Don't say $999. Just tell me it's $1,000, okay? So that's the same here. It's not a discount with $199. It's a discount about $200 directly, okay? Yeah, exactly. For those candidates who are preparing for July exam, I suggest strongly another thing rather than the crash course, the regular course, which considered full surface to all candidates, including everything you can imagine for your preparation, okay? This is some feedbacks from our candidates who successfully passed the exam. I'm really being very happy when I saw these feedbacks to all of us. I mean the team of mid-exam, because believe me, we are doing a very difficult job to satisfy everybody and to reach the mentality of each candidate. It's a very difficult job. It's apparently easy to keep yourself updated according to the new guidance, which is developed every day, to understand all new papers published by TOG or by the British societies of different medical situations and difficult societies. It's very difficult, okay? And finally, to help different mentalities to understand the principles and to pass the exam, it's a very difficult, but which make us happy, these feedbacks, always, all of us being very proud to see these feedbacks, me, Dr. Zaid, Dr. Helmi, Bradnia, Dr. Bradnia, and all of us, either in part 2 or part 3. So this is what we are mainly working for. We are open always to receive different feedbacks. Don't be shy. Don't hesitate to give us negative feedbacks, and we will try to manage. We will try to accept the idea, and we will moderate the problem to recover this point and to reach our aim, which is finally to satisfy everyone. And another gift from my side, now it's fine. It's directly $200 discount, not $199. I'm happy with that. For the course, the regular part 2 preparation course for July. Aspirants, I'm so much talkative. Thank you so much for all of you for being with us today. I was very happy again and again, and very proud to see all these
Hi.
people in the room.
Hi,
Yes,
sir.
hi.
Hi, assalamu alaikum. How are you,
Dr.
sir?
Zaid. How are you?
I'm good, alhamdulillah. Thank you so much
Alhamdulillah.
for such, the useful session, I must say. I want to ask one thing. I have one young patient, 15 years with the tubal ovarian abscess.
Yes, yes, sure.
And I have treated her with symptomatic treatment, but somehow, her cyst has got reduced. But she is asymptomatic, but cyst from 14 centimeter, it has gone down to 8 centimeter. And it's been like 2 months. So, but she is asymptomatic. So what should I do furthermore for this patient?
Yeah, actually, if the symptoms are absent, there is no symptoms.
Yes.
And the sac is regressed.
Yes.
Okay. Now we should exclude. Now we have no problems with increasing the cyst size or persistent cyst. So re-scan after another 3 months will be appropriate option in this patient. Okay.
Okay.
Re-scan again, because if according to the flow chart, if the after 3 month rescan, if the patient cyst size less than 5 centimeters, or let's say less than 7 centimeters, if the patient has the problem resolved, it's okay. If not resolved, increased in size, or still persistent, go for a management plan directly. But with cysts more than 7 centimeters, like your case, 14 centimeters, okay? The first option is surgical intervention, laparoscopic cystectomy, after exclusion of malignancies by 1, 2, 3, as we discussed. If the patient in your situation either refused surgery or asymptomatic, want to wait, and the size of cyst markedly regressed like what you described, then we can keep following up her by rescan after 3 months to re-evaluate finally the situation. You got my point, Dr. Zaid?
Yes. This was exactly my plan, and today I think it's been like 2 months exactly. So, but till now she is asymptomatic, no problem at all. And earlier when she presented to me with this much cyst, she was having continuous vomiting and abdominal pain and everything. But on the MRI, even it was clear tubal ovarian abscess, with the clear picture, and even on the doctor scan as well, no flow, nothing. The tumor markers were normal. So I kept her on the antibiotics and all. So after 7 days, she got very much better. So
yes,
now
exactly.
she's not having. Yes,
I
she's
think
not
you
having any
did
kind of.
you did the ideal way in the management of this case. Yes.
So I thought it's the right time to discuss this case with you, because discussing the
because
abscess
it's a
and
related
everything.
topic, exactly.
Exactly.
Related to the topic directly. Thank you, Dr. Zaid. I appreciate so much your presence.
No, I really value your opinions in gynecology. You know me, I always discuss everything with you. And remember the case I discussed with you, and it found out to be the cyst on the labia as well. Remember, I have sent you the picture. Yeah, it was
I remember
sebaceous
this
cyst.
one.
Yeah, it
Sebaceous
was.
cyst, yes.
Yes. And I am
Thank you.
writing a case report on that as well. So probably, I will show you.
Yes, I will wait for this. Yes, please send it
Okay.
for me. Yes, of course, of
Okay,
course.
I will.
Dr. Zaid, you are always amazing, and your cases are always challenging. And this is related because I think you are a pioneer in your practice. So I think you always being in difficult situations. God bless
Yes,
you
sir.
always. God bless
And
you
I always
always.
take your help, and I really
Thank you so
appreciate it.
much.
Thank you
It's
so
my
much.
Good
pleasure and
evening.
my honor. Yes.
Good
Hey,
evening.
good evening,
Hassan Haider
sir.
here.
Hi, good evening, sir.
Good evening,
Thank you
Dr.
so much,
Hassan.
Dr. Hassan. Thank you so much for the informative session. Thank you for sparing the
Thank
time,
you.
and it was lovely hearing you.
Thank you.
So I must say that we have a great panel at MedExam Expert, and everybody should take a benefit from these experienced mentors who have a huge clinical experience with a variety of cases they have handled. So maybe soon we are also starting some sort of a series in which our expert panel will be discussing some complicated cases, and we will be sharing those videos with all the students just as a knowledge sharing. So we're working on that, and maybe soon we'll launch that as well.
Wow.
Yes,
So
sir.
thank you so much.
Actually,
Yeah. So
I just was talking to the candidates all to explain to them it's how much difficult to maintain a good work, keeping the candidates in the mood, improve their qualities, and then finally to gain the maximum outcome from this exam and from this course as well. It's very difficult work. The back team of MedExam Expert, people who are working 24 hours per 7 days, answering questions, preparing groups, preparing links, preparing PPTs, improve the website themselves. I would like really to thank them all. Okay, I know they are listening to me right now, so I would like to thank them so much
Yes,
and
exactly.
asking them to keep working. They are doing a great job to everyone. Thank you so much, Dr. Haider. Thank you, Dr. Zaid, so much for being here with me today. Thank you for your support. Thank you always for everything. And I would like to ask all candidates from now, start your preparation, be ready for exam. Success is yours. Thank you so much.
Exactly. Work hard. There is no shortcut. Okay.
Exactly.
Yes.
Do your
Okay.
job. We will do our job. And finally, we will all celebrate. Thank you so much. See you.
See you, sir. Thank you so much.
Bye-bye.
Bye.